Let's talk about strategies to prevent and manage recurrent C. difficile infection. As we all know, this is a common infection that affects people in the hospital and outside the hospitals, and a sizable fraction of people recur. After an initial episode, about 20% recur. After 2 episodes, about 40% recur. And after 3 episodes, based on other underlying risk factors, 60% or more people tend to recur. There are several strategies that you can use to prevent recurrences. Let's look at all of those. Strategy number 1. Try to modify or get rid of underlying risk factors that are modifiable that lead to C. difficile. These include exposure to other antibiotics. If you can limit other antibiotic exposure, that's ideal. If you have to use other antibiotics, maybe use narrow spectrum antibiotics for the lowest duration of time. Reduce other exposures. Try to cut down on PPI dose or perhaps stop PPIs if they are not indicated. Try to limit exposure to healthcare settings and other places where people can get exposed to C. difficile. So that's strategy number 1. Try to take care of modifiable risk factors for C. difficile infection. Strategy number 2. Antibiotics are the mainstay to treat C. difficile infection. They are effective, but unfortunately can lead to recurrences because some of the antibiotics that we use to treat C. difficile, namely vancomycin or metronidazole that's rarely used, disrupt the gut microbiota compared to some of the other ones like fidaxomicin, which are more narrow spectrum. Ideally, one would like to use narrow spectrum antibiotics to treat C. difficile if they are available and if cost is not prohibitive. Fidaxomicin in a standard dose of 10 days or with an extended regimen where you can use the same number of pills up to 25 days can help reduce recurrent infection. So strategy number 2, try to use narrow spectrum antibiotics if available. Strategy number 3, our body mounts an immune response against infections, and same is the case with C. difficile. Initial studies showed that if you mount a high immune response, your risk of recurrences is low. This was translated to therapy. Studies have shown that if you use a monoclonal antibody against the toxin B, known as basilotocimab, you reduce your risk of recurrence. This was shown in 2 large phase 3 trials of over 2,500 people where the risk of recurrence with basilotocimab when used in addition to antibiotics was lower compared to placebo in use to antibiotics. Basilotocimab is available. It's an FDA-approved therapy, and it's useful in people who are at a high risk of recurrence. Who are those people? Anybody over the age of 65, anybody with their prior C. difficile infection in the last 6 months, anybody with severe C. difficile, or somebody who's immunocompromised. If you have one or more of these risk factors, you would have a recurrence prevention benefit from basilotocimab. So that's strategy number 3, enhance the immune system. And then strategy number 4, try to address the underlying pathophysiology that leads to C. difficile infection. The risk factors for C. difficile, predominantly antibiotics, disrupt the underlying gut microbiota. This underlying gut microbiota is further disrupted with some antibiotics that we use to treat C. difficile, and unfortunately patients get into cycles of recurrence. Restoring the underlying gut microbiota can break the cycle of recurrence. This is typically in clinical practice used for 3 or more episodes. The most common way of doing this in clinical practice is an experimental treatment known as fecal microbiota transplantation. This is where donor stool from donors who are well screened for health conditions and infections is taken and processed and sometimes administered via a colonoscopy and at times administered via capsule-based forms. This has been shown to be effective for patients who have recurrent C. difficile infection to break the cycle of recurrence. FMT is heterogeneous, it's unapproved, and availability has become scarce since the COVID-19 pandemic. With all of these challenges with FMT, several microbiome-based therapies are being developed. At this time, there are 2 therapies that have completed phase 3 clinical trials. One of them is RBX2660, which is an enema-based therapy and has shown positive data in phase 3 trials. And the other one is SER109, which is a capsule-based therapy and again has shown positive data in phase 3 trials. Both of these would be up for FDA approval in the near future. And there are other therapies that have shown positive phase 2 data. CP101 is a capsule-based therapy with positive phase 2 data, and VE303 is a defined microbial consortia not derived from donor stool and has shown positive phase 2 data. So in today's world, there are several ways of us trying to prevent recurrent C. difficile infection. Eliminate modifiable risk factors. treat with narrow-spectrum antibiotics, use immune-enhancing strategies, and then finally try to restore the gut microbiota. Thank you for your attention.